And without any further ado, I want to begin our program on heart disease today. And we're going to begin the program with Dr. Harris Efron, who's a former chief of cardiology at Kaiser, and he's retired now, but he actively involved at UCSD teaching new doctors, and obviously knows an awful lot about heart and heart disease and end-of-life options that people face around heart disease. So he's got some slides he's going to show you and talk to us about this issue. So without any further ado from me, Dr. Harris Efron.
Good afternoon. Some of you I have met professionally, others welcome. There are two. We'll go over a little bit of heart failure. I'll try to make it relatively non-scientific, but enough to give you guys a feeling for what we deal with. I've been a cardiologist for about 40 years, and as introduced now, I teach first and second year medical students over at UCSD, which has been absolutely wonderful and rewarding. Heart failure is something that I'm pretty passionate about and have done for many, many years. If despite my feeling for the scope of what congestive heart failure is, every year about 600,000 new cases of heart failure are documented in America. And if you're over the age of 60, there's about a 10 to 15% chance that at some point in your life you're going to have congestive heart failure. If you put all the causes of death together, heart failure is by far the #1 cause of death in America, and all of the cancers put together do not equal the mortality of congestive heart failure. And it's a very interesting sort of phenomenon. In America, you can't die from heart disease because we've got all this great technology. You can die from cancer, that's fine. You can die from dementia, but certainly not heart disease. When surveys are taken, about 3/4 of the people in our country don't realize the magnitude of what congestive heart failure is. And in fact, in terms of Medicare costs, the numbers are in the billions of dollars every year. So much that one of the major Medicare issues when it comes to heart disease is readmission of patients with heart failure within 30 days of hospital discharge. And the numbers are staggering. Almost 40 to 50% of all patients discharged from the hospital are readmitted within 30 days because of recurrence of symptoms of congestive heart failure. So, real basically, what are we talking about? Heart failure is a situation where the heart muscle is no longer capable of pushing blood forward to nourish your organs. And clearly, if the brain's not getting adequate blood supply, the kidneys, the GI tract, even the heart muscle itself, there becomes a real problem. And your body reacts to lack of blood flow to these organs by assuming that there's not enough blood in the body. And so these organs tend to try to do everything they can to retain fluid. And you'll see, if any of you in the audience have been victims or know folks with heart failure, that what we call edema, or shortness of breath typically because there's fluid in the lungs, edema because fluid is contained in our peripheral skin and under the skin tissues. It's because the body is telling us do everything we can to provide more volume and circulation so that these organs can get an adequate amount of oxygen and nutrition. So that's the basic type of definition of heart failure. There are really two kinds of heart failures. The one that most of us in the room are familiar with, we call that systolic heart failure, where a part of the heart muscle is no longer contracting well. As we have gotten older and our population is significantly aging, a second type of heart failure has emerged that's far more difficult to treat, and this is called diastolic heart failure. And with that, although the pump of the heart is working well, the heart actually stiffens with age. The pump is there, but it's just harder to fill that pump, and so the pressures in the heart rise, and when pressures in the heart gets significantly elevated, that pressure translates into fluids instead of going forward into your body, backing up into the lungs, backing up into the liver, backing up into the GI tract. So symptoms of things like shortness of breath, again, swelling of the extremities, nausea, abdominal girth distension, something we call ascites, which is fluid built up into the abdomen. These are very, very common signs. And both systolic and diastolic heart failure have different origins. We found over time that the treatments are almost the same. And there are lots of different levels of treatment. Basically, in a nutshell, the first thing we have to do is figure out, why does a patient have heart failure? And there are lots of different reasons. Anybody in the audience have any thoughts about what sort of things might trigger congestive heart failure? Yes, ma'am.
Diet?
Sure, absolutely. And as I'm sure everyone in this room is aware, obesity, particularly obesity in the young in America, is now pandemic. Almost 35 to 40% of kids under the age of 15 are now considered clinically obese, which is, compared to 30 years ago, a huge difference. So certainly diet and nutrition, and there's so many other diets around, everything from vegan to Mediterranean. Yes, ma'am?
High blood pressure and cholesterol.
Again, perfect examples. And these are all examples of things that are treatable. High blood pressure, cholesterol, smoking. One would think that the incidence of smoking in America has gone down. Unfortunately, among certain populations it has, but among the youth in America, everything from vaping, which is a concept I'm sure many of you have become aware of, which in and of itself starts satisfying the brain's need to have something in your mouth, and it's either going to be food, or as we get older, it's going to be cigarettes, right? Not even that, but if we're talking about issues like smoking, we can talk about drugs and toxicity of drugs. Amongst the younger population, methamphetamines and cocaine is one of the largest reasons for hospitalization for heart attacks now in people that are under the age of 30. So again, it's translated into some amazingly difficult things. I see a hand.
What about cardiac arrest?
Okay, so I think you said cardiac arteries blocking?
No, cardiac arrest.
Oh, cardiac arrest. Okay, we'll talk for a second about that. But clogged coronary arteries, this can be a genetic problem related to cholesterol and lipids like you were talking about, or it can be as a consequence of the multiple risk factors we've talked about. Lack of activity is another one, obesity, smoking, hypertension, nobody in the room mentioned diabetes. Type 2 diabetes now is being seen both in kids and in adults. Very, very frequent, and again, one of those things that clearly can be modified. Is anybody familiar with the term sleep apnea?
Yes.
Okay, so again, this goes hand in hand. There are two different types of sleep apnea, actually. One that's associated with actual obstruction that we see often in people with obesity, where their brain is telling them to breathe, but because of their palate, lots of things in the mouth, there are physical obstructions to breathing. And the second is what we call central sleep apnea, where the brain just doesn't remind us to breathe. And this sets up over time during your sleeping hours, times when your brain and your heart are getting adequate amounts of oxygen, but then when you're not breathing, the amount of oxygen goes significantly down, and these changes in oxygenation in your tissues can make a huge difference in terms of how your end organs, like the heart and lungs, tolerate things.
How
So-
about the heart nerves in your back and your spinal cord?
Well, we can talk about the nervous system as well when I get into heart failure a little bit. One of the other things, coronary artery disease, of course, which is rampant in our population. I have spent most of my life putting in stents, and as you know, the controversy for stents is, well, they don't save lives, and for the most part, stents don't save lives other than certain clinical situations, like being in the middle of a heart attack. What a stent does, it opens a narrowed artery to allow more oxygen to the heart muscle so it can improve your symptoms. But it's like putting your finger in the dike. There are so many arteries with blockages that may not be critical, but may be the blockage that ends up causing your heart attack. Because literally most of the time, It's not hardening of the artery that leads to a heart attack. It's rupture of what we call a cholesterol plaque, even in an artery that could be only 30 or 40% blocked. Once that rupture occurs, debris from the cholesterol plaque enters your bloodstream and causes all sorts of bad cells to congregate where this rupture occurs. An artery is completely narrowed, and at that point in time, you have a heart attack because there's no blood able to get past the obstruction. Another common reason for congestive heart failure can be congenital or birth defects. You can have, for example, birth defects of the valves of the heart. You can have a very rare but fortunately treatable conditions that are called cardiomyopathies. Cardiomyopathy is a weakness of the heart muscle itself, and it can be familial. It can be from something as simple as catching a flu and being a very unlucky person, because that flu virus can actually make the heart a target, and you can get what we call an autoimmune response that often can cause a normally functioning heart within a matter of days to weeks to be a floppy organ that's completely and totally inefficient. So how we take care of congestive heart failure. Congestive heart failure is sort of an end product. There are lots of types of heart disease, as we've noted, that can lead to congestive heart failure. There are medications. The first line of medications, again, it's not going to make you live longer, but make your quality of life better, is something called diuretics. And there's a whole variety of diuretics that typically will work at least early on. If we find that diuretics are not working in patients for heart failure, and if the patients are appropriate, we can put patients on things as drastic as hemodialysis to get excessive fluid off the body. And there are other types of dialysis which are a little less invasive that can be done in the hospital setting as well. To get to your point about the nervous system and the heart, when end organs like the brain and the gut and even the heart muscle are seeing there's not enough oxygen getting to us, we better make that heart start pumping faster and harder. Although it makes logical sense to be asking the heart to do more work, most of the time the heart isn't able to do that. And so one of the things we found is that if we give medications to make the heart beat stronger, in the very short run it may work, but in the long run it's going to tire that heart out and actually lead to premature death. So we have a whole class of drugs that are called beta blockers. Most of them end in two letters, OL, and those beta blockers are designed to do a couple of things. They relax the heart, make filling of the heart a little bit easier, and often can also help us take care of things we call arrhythmias. One of the problems with congestive heart failure and lack of oxygen to the heart muscle is that it gets irritable. And when it gets irritable, you can get irregularities in the heart rhythm. These irregularities can at times be life-threatening. So the beta blockers help in allowing us to calm the heart down and in many cases lessen arrhythmias. One of the nice things about that category of drugs is it doesn't have many of the more toxic side effects that other drugs can have, okay? Again, along with the body's need to replenish fluids because these organs don't think they're getting enough, there's a whole set of enzymes in the kidney and liver. It's called renin and angiotensin. And all the commercials on television for medications like Entresto that you may have seen regularly that are helping patients survive at heart failure deal with modifying the kidneys so that they don't retain as much fluid as they want to. If we find in patients that despite being on these regimens to help out the heart muscle, to relax the muscle, help eliminate fluids, there are still patients that are not going to do well from several standpoints. And then we get away from the world of pharmacy and we get into the world of mechanical treatment of heart disease. One of the first things we can do if patients are appropriate candidates, and our panel will talk a little bit about what appropriate candidates are, is we can actually insert a pacemaker-like device. There's a whole area of cardiology now called resynchronization therapy. A very long word, but basically what it means is that there's a right and a left side of the heart, and if the basic muscles on the right and left are not synchronized, the heart will not be as efficient. So this type of pacemaker actually has 2 wires in it. It can go to both chambers that do the pumping on the right and left sides of the heart, and they make sure that the heart is beating in a coordinated fashion. And in addition to being a synchronous type of pacemaker, we can often add something called a defibrillator. And many of you have seen AEDs all around the city. A defibrillator is the quickest and most efficient way to stop a life-threatening rhythm disturbance that occurs to the heart. Seattle is probably the best city in our country in terms of public awareness of how to do resuscitation, how to use AEDs, and in the best of situations. If you're unfortunate enough to have a collapse on the streets because of a heart arrhythmia, the chances of you leaving a hospital in anything other than a vegetative state are probably less than 10%. So it's a great thing to have, but it has to be applied immediately. And for those of you in the audience that are sports fans, you can remember probably about 30 years or so ago, Hank Gathers, who was a Loyola Marymount basketball player going to the NBA, was playing in one of his final college games, and it was on CBS, and he suffered a cardiac arrest. A defibrillator was not available. He never left the playing floor. And at that point in time, with millions of people actually watching this event, the whole issue of having defibrillators and the importance of getting to a patient quickly then became a paramount focus in cardiology. So we're talking about more mechanical stuff. We have these pacemakers that can be fit with defibrillators that can immediately shock the heart out of a life-threatening rhythm. If despite all this, patients are still doing poorly, there are some other technologies that are available. Excuse me. Yeah.
I'm wondering, in light of this audience, you might want to comment a little bit on the new problem we have, that to the extent that we establish a new rhythm in that patient at the airport, as you say, only 10% are going to walk out of the hospital in reasonably good health. Most of them are going to die, but a whole bunch of them are going to be suffering a lot of brain damage. And I think that's one of the things that's very concerning here, is we don't want to be one of those people that has been resuscitated only to have significant brain damage. Can you give us a little bit of the picture?
I certainly can, and I think what I'd like to do, if it's okay with the audience, is let me go about 5 minutes longer, because we're going to talk about issues right along those lines, and we'll come back to that. Please don't let me forget, okay? So, amongst the newer options that we have are devices that actually take the place of the heart. And this is right where you guys are sitting. The first approach to people that are not doing well despite the medications, despite the sort of pacemaker with a defibrillator and the synchronous behaviors of the heart, is something called ventricular assist devices. So these devices can be placed into the chest, and they actually connect with the heart. There's one side of the device that plugs into the major pump of the heart. By vacuum, it sucks blood out of the heart, and then the other side of the pump delivers blood to the aorta, which is the conduit through which all blood flows to our organs. So ventricular assist devices are often used, again, in appropriate settings to make several different determinations. One, is this going to be a short-term kind of congestive heart failure where we're expecting the person to survive and all we need to do is support their heart for a matter of days to weeks? Secondly, is this going to be an appropriate patient to consider for heart transplantation? Thirdly, is this going to be an appropriate device for a patient who, for whatever reason, would not be a candidate for heart transplantation, but rather can be a destination device? That is, for the next 3 to 5 years, this person will have a reasonable quality of life, understanding there is a machine that's partially assisting his heart. Okay? So the LVAD or RVAD, left heart or right heart, these assist devices have been around now for several years. 3 to 5 years survival on these is not unreasonable. If we end up going to heart transplant, The numbers are amazing. Unfortunately, there are not many patients that have heart transplants in America for lots of different reasons. Economics is usually the least of them. A lot of this has to do with family support, the arduous regimens that people have to do for heart transplantations, etc. And the curve has been relatively flat in terms of heart transplants. Particularly in California, one of the problems has been donors since the motorcycle helmet laws went into effect several years ago. So, you know, again, it's an ironic fact, but it is true.
Maybe the scooters will make up for it.
And these decisions to proceed with LVAD devices, to proceed with the consideration for heart transplants, are certainly not decisions that are easily made. These decisions are not made only by a physician, but in fact there are teams that consist of folks that do palliative care and hospice. There are all sorts of psychosocial factors that go into this. There are all sorts of community factors, religious affiliations, some of which would support mechanical devices, many of which would not support mechanical devices. So I think it's very important for us to understand that these further technologies that are available are not right for everybody. And I will tell you, having done this for 40 years, that there are families that have been never happier until the stress of dealing with a terminal illness is dealt with by palliative care and supported by both the primary care physicians who really know the patients best and the cardiologists and other specialists that have worked as a team. It involves occupational therapy, physical therapy. But some of the results are staggering. The chances of living 10 years with a heart transplant are 75 to 80% of a near normal life. But again, the donors are not always there. Of course, we have to use matching to make sure that there's not an antagonism between the donor heart and the recipient person. And the technologies are overwhelming, but are they for everybody? And who makes these decisions? I would certainly say to everybody in this room that you want to have your wishes known. They need to be made clear on electronic medical records. You don't want to be one of those people in the airport that has a do not resuscitate order somewhere, but they're traveling by themselves. And as the gentleman mentioned, all of a sudden there's a collapse, there's a defibrillator right there, the person is unconscious. We have no idea that they've got terminal cancer or another terminal illness and that their quality of life has been awful. So again, these are struggles that we deal with all the time, and we are committed as physicians, if there is no knowledge to the contrary, to do everything we can at that immediate moment to support life. Okay? Yes, ma'am?
Are you saying then that someone should carry, everybody should carry their wishes like a living will on them at all times?
I would certainly have at least a bracelet that talks about medical
Do not
conditions.
resuscitate?
Absolutely, if it's possible, and it's in, as I said, it's something that we have written somewhere, or there's a number to be able to communicate to so people know, or something in your wallet, right? Something, if you
You know,
don't,
the urge to help before going into someone's wallet. You know, people do
Right.
before they switch to help.
That's correct.
Rather than start questions, I know you folks have lots of questions. We're going to allow lots of time for questions. I'm afraid if we start answering questions now, we won't have time to hear our other panel members. So let's wait on the questions, and then we'll come back and be able to tap everybody.
And if we had slides, it would have been even.
Yes. Wonderful presentation by Harris, and on the fly. Can you imagine that? That sounded almost like it was written and he was reading it off a script, but it was all up here. Wonderful.
Yeah, I've done it once or twice before.
Yeah. We also have on our panel a couple of other doctors who also are going to tell us additional information about heart disease, and I guess, I think, is it Jim next that we're gonna?
Sure.
Whatever.
Okay, Jim Sinclair has talked to the Hemlock Society before. Jim is actually an oncologist, but he's also been the medical director of hospice, and in that position, he's had lots of exposure to people with end-stage heart disease, and in an environment which we need to know about, or at least will inform what he can tell us about heart disease in the last stages of life. So I think, without any further ado, Jim Sinclair.
I finished my training in '87, so I've been an oncologist for a number of years, 30-some years, and got into hospice naturally because we heard that cancer patients die, heart patients don't die. So I was in a field where a lot of people die, and we didn't have any really good way to take care of them at the end of life. So in the early years of my practice, it wouldn't be uncommon for me to have anywhere from 10 to 20 patients dying in the hospital. So I'd have to make rounds every day. There they were, comatose in bed, nothing happening, but there was nowhere to go because hospice really hadn't taken off. So I got involved very early in the 80s and have been involved in hospice ever since. And of course, once I got into hospice, it's not just about cancer. In fact, cancer is not our #1 diagnosis. It had been way back in probably the 70s when hospice first started. In fact, I think Congress thought that that's all it was going to be, was just cancer.
It started in '84. My cousin, State Senator Jack Gordon of Florida, introduced the first hospice bill in the nation in 1984. The feds got a hold of it in 1986. Changed it from 1 year in Florida to 6 months.
Well, amazingly, the resources have been very helpful for a lot of people at the end of life. Maybe many of you will use hospice services. One of the things I learned early on is that every case that gets referred to us is different. Even every cancer patient is different. And certainly when you start to look at the other illnesses, the top 5 would be heart disease, lung disease, neurodegenerative diseases. Certainly cancer is up there. These are the illnesses that people have as they enter the later phases of life. So we learned very early on with cardiac patients that their needs were quite a bit different than the dying cancer patient. Many of the heart failure patients were on a large number of medications, and our first job was to figure out, now that they're entering that final phase, do they need all those medications? For example, they probably don't need the cholesterol drug anymore once they've entered that final phase. It's unlikely that that's going to matter, although I can tell you at our hospice, it's a battle because the cardiologists do such an amazing job of teaching people. If you want to reduce your risk of heart disease, you've got to stay on this cholesterol medication. So we have to wrestle with them to get them off that medication. There are other medications we have to try to deal with. Anticoagulants sometimes become more risky when they're stumbling on falling and injuring themselves. So we try to talk with the families and the primary care provider to educate them. This is a change. The big fear patients have at our hospice is that we come in, we take away all the medications. Well, no, that's not our goal. Obviously, our goal is to focus on what are the medications that are going to keep you comfortable and what are the medications that are actually now contributing harm to you. And it's an opportunity. And that's not just true for heart patients, it's true for cancer patients and dementia patients. Another thing I can say that we've not had too much challenge with is that defibrillator you heard about. Because a lot of patients come to us with a pacemaker defibrillator. The pacemaker doesn't really give us a whole lot of trouble, but the defibrillator, when you get very close to the end of life, can be a bit of a challenge, not only for the patient, but for the family and the staff. So it's something that we want to know about right off the bat. Do you have a defibrillator? And if you do, what are your plans as you get closer to the end of life? Thankfully, our cardiology friends have an ability to turn off the defibrillator component so that when they're at the end of life and they have their terminal episode of ventricular fibrillation, we don't all get a shock that they turn the defibrillator off and the patient dies of a natural event. As far as LVADs are concerned, we've struggled with LVADs. That's the mechanical device. It's a challenge. Our Orange County program has taken on a couple of patients with LVADs. Why would an LVAD patient come onto hospice? Well, eventually other organ systems begin to fail, and the patients do decline in spite of the technology. And so we have to learn, how do we manage that patient towards the end of life? And I want to give an example of a patient I saw recently that's a huge challenge. He's not on hospice. A young man, probably in his mid-60s, African-American gentleman who had basically been dwindling over the last 3 to 6 months. Otherwise, pretty healthy, no major medical problems. But he came to the hospital and was found to be in florid heart failure. Very serious. He ended up on something called ECMO, and then eventually another device. Very quickly, it turned out that he had an unusual cause for his heart failure. He had something called multiple myeloma. That's why I got to meet him. That's a cancer. So he has a cancer, and his multiple myeloma caused material to build up in his heart muscle called amyloid. And it built up in his kidney. So his kidneys were failing. So he was on artificial support for his heart, artificial support for his kidney, and then they asked us, well, what can you do? Well, under normal circumstances, we can treat multiple myeloma. It's a disease, it's considered a blood cancer, and there are a lot of very effective medications that will manage that disease. But unfortunately, those treatments tend not to reverse the heart failure, they tend not to reverse the kidney failure. And so this poor gentleman was going through quite a challenge, and the heart failure doctors at our hospital were really challenged because I think you're going to hear that amyloid heart failure is not a popular thing to go to transplant. Most transplant centers will not take patients with amyloid heart disease. He was on dialysis as well. And my colleague, who was the oncologist, was trying to figure out, is this a situation where we want to bring in chemotherapy to try to keep him alive longer while he's on dialysis and was about to be considered for the LVAD because his heart was just too weak to be functional with medications. Well, when I left it, there was a team from the heart failure team, palliative care, social services. There were a large number of people getting together, the patient and his family, to figure out what are our options here. And the options were very, very limited. And it's very possible that he may end up either going to a facility or going home, maybe without the LVAD, maybe with it. But his lifespan is very, very limited. And I think that we love technology and medications. I'm an oncologist. I give chemotherapy, God forbid. And there are patients who are certainly alive because of it. However, everything comes to an end, whether it's heart disease, cancer, dementia. And I think the hospice world has to understand that as this new technology comes in, we have to be savvy. We have to understand that the medications, we need to understand what these medications do, which ones we maintain, which ones we don't. It's a very important transition, going from aggressive care to palliative care to hospice. And we are not in the business of killing people, but we are in the business of allowing them to have a comfortable passing and not support prolongation of life. And yes, we have patients who choose to use the option that's available in California, and you may hear about the experience that the other hospices have. It doesn't happen often, but when it happens, it's a very interesting experience, not just obviously for the patient and family, but for the hospice staff. And the last patient we had with ALS that did this about 2 weeks ago, he was with us for about 6 to 8 months, became a young man, so he became very strong emotional relationships with our staff. So when he passed, it was a challenge to help our staff with their bereavement, but he got what he wanted. He did it on video. In fact, it'll be out on Netflix soon. He's a producer, so I'm sure you'll see it. It'll be one of your movies, I'm sure, one of your days. But for me, the challenge is to understand where are we at in the transition process. And for heart failure patients, after they've been aggressively managed with lots and lots of medications and equipment, how do we begin to transition that into things that work? And perhaps I'll stop there. You can hear about all the wonderful things we can do for end-of-life heart failure patients from my colleague. Thank you.
Thanks, Jim. And finally, we're going to hear from Dr. Lisa Eickhoff, retired gerontologist from Kaiser, and then we'll take time to have questions. I know you have a lot of questions for everybody on the panel, and we'll have plenty of time to do that. So, Lisa, I'll let you start.
Thank you. Well, thank you for having me back. I've spoken to this group before. And so I'm a geriatrician, palliativist, was medical director for Kaiser Hospice and palliative care for a long time. And I'm still working a little bit per diem. And I've been involved in the end-of-life option work since the law was passed in 2016. And that has been very interesting and actually very fulfilling work. So my colleagues have done a great job, I think, of setting the stage about what makes palliative care, hospice care, end-of-life care in the congestive heart failure world, and even in the COPD and emphysema world as well, somewhat more challenging than with cancer. I'll have to tell you, a lot of hospice teams are like, oh good, a cancer patient, great, we know how to do that. Like, that's easy, we got that, yeah. Whereas a more complex heart failure, with renal failure, with maybe some COPD, they're like, this one's gonna be harder. And there's gonna need to be more medical involvement of the medical team. And the reasons have been laid out, but I'll just kind of reiterate them. Part of the issue is that, unlike with a cancer patient is either still receiving chemotherapy or it's been determined that it's no longer effective. We stop the chemotherapy, we change the focus of care. It's all about symptom management, pain relief, shortness of breath, nutritional support, all of those things that we all know about. It's a clearer line. With heart failure in particular, you can't just prescribe like we do with a cancer patient, because the combination of the diuretics, the combination with the beta blockers, all of these medicines that Dr. Efron mentioned are keeping the patient free from feeling like they're drowning in their fluids. And if you just stop them, you're going to really pull the rug out from under, and they're going to go into some acute congestive heart failure and be very uncomfortable. So sorting out which drugs you can stop, the statins, which people are often quite committed to, the blood thinners, which is sometimes a tougher decision, but if a person's very weak and been falling down, banging their head, and they're covered with bruises, it's time to stop that. But the things that are really going to cause acute symptoms, it's a lot harder to kind of stop that show and figure out where to go with it. We do often deprogram or turn off the defibrillator part of a defibrillator pacemaker. Some people ask to have a pacemaker turned off. That can be done, although it depends whether the person is dependent on that pacemaker for every heartbeat, or the heart is still working on their own. The pacemaker is just there to kind of catch them if they fall too low. So there's some challenges, because you can get close to that line of actively causing the patient's death. And the only environment in which we're allowed to actively contribute to the patient's death is in the very strict guidelines of the end-of-life option work. I will tell you that one of the challenges of the end-of-life option work is the restriction of the 6-month prognosis. When you have a patient for hospice, and you say, the normal course of the illness will be 6 months or less, but you know that with hospice you can re-up the hospice benefit, you can take somebody off if they get better. You've got some time to sort of see how things go. The end-of-life option work, if you deliver medications to patients and they ingest them, that's it. The story's over. You don't get to really reassess things too much. And that's caused some challenges with some of my colleagues, where the palliativist goes out and says, I think this person's qualified for the end-of-life option work. I think they have a prognosis of 6 months or less. But sometimes the cardiologist might not see it that way. They'll say, oh no, we can continue to walk, juggle these meds, and I don't think it is 6 months. I think it could be longer. And then you kind of can't move forward, because the law is very specific about 2 opinions, and it has to be pretty consistent around that. On the other hand, patients get to choose what medicines they will and won't take, and so a patient can change that prognosis based on their willingness to accept ongoing treatments and take the medicines or not. So unlike with cancer patients, this can be trickier, and we sometimes have more differences of opinion among different doctors in the congestive heart failure realm with the end-of-life option work. So that has been a real challenge for us as we've tried to implement that law. I think maybe I'll stop there. I think the other issues have been covered in terms of the challenge of changing direction and changing the medication regimen to promote a good dying experience and end-of-life experience. Once people have been on some of these medicines, it's challenging to pull them away completely. I will say that people sometimes forget that morphine is a great drug for the symptoms of congestive heart failure. I'm old like Harris, and we used to get called down in the emergency room. Somebody was in acute florid pulmonary edema, and the first thing we did was give a big shot of morphine, right, back in the day, and it relieved the pulmonary congestion. And so when you get right down to it, at the very end of life, many of the same medicines that we use for end-of-life symptoms in cancer patients or any other patients work just as well for our heart failure patients. So we do have those tools. Sometimes it's just getting to that very late stage that's trickier. So I think I'm going to stop there because I'm sure there are a lot of questions and comments.
Well, first of all, great presentations by all of our panel, and I really appreciate them coming and sharing what they know with us. Now we get to what you've been holding back. So you have questions, I know, and I'll let you fire away, and if you'll tell me who you want to direct the question to, then I'll say shoot.
Do you want to make the announcement that we are recording?
Oh, yeah, it is important. Ken reminds me it's important to remind the audience that if you ask a question, we tape the presentation, and that means we'll tape your presence and your question. And so keep that in mind when you think about asking a question. We're happy to do it. We just want to make sure you're okay about it. And if you're okay about being taped, then
We don't put
Quick.
the camera on them.
no, I think we hear the question.
Yeah.
Yeah.
My question is directed to all of the speakers that I enjoy very much. But I hear when you're speaking and you're presented with a person that is either comatose or near comatose, and you make the assumption that, well, yes, they want to have preserved life at all costs. What about, are you sensitive to the patients who are not necessarily wanting to preserve life at all costs? On the contrary, they're looking for a way to get out of this life.
Yeah. In case you didn't hear the question clearly, the gentleman wants to know if these doctors, when they're presented with a patient who is comatose, whether they are sensitive to the fact that this particular patient might be just as interested in getting out of life as being pulled back into it. And I'll let them speak to that issue.
Pass
Is
the
the-
mic.
the mic passed? Yeah.
It comes out, just lift it out.
Yeah, I'm
Just lift it out.
There we go. Yeah.
Go ahead.
That's about as far as it goes. So if you're gonna.
No, there's outside, yeah. Underneath, there's a lot of room. There's a lot
Yeah. Okay. Yeah, that's a good way to do it. Yeah. There you go. Yeah. I think that's as far as it can go. Yeah.
I mean, this audience is carrying Coles to Newcastle to talk to you about advanced directives. So obviously, the conversation needs to take place before one becomes comatose, although you never know, you can have a sudden heart attack. But this is why people need to discuss their advanced directives, have things on paper, have somebody identified who could be their surrogate. So, a comatose patient doesn't just show up at the hospital with no context. We usually are able to identify, something about that patient, who their surrogate decision makers are, what kinds of things they've expressed about what they want. So, yes, absolutely, our goal is to identify the patient's wishes as very best we can, based on the substituted judgment of their decision makers, and follow those directives. So in the emergency setting out in the community is where this happens. I don't know if did people see the controversial case where a gentleman had put "Do Not Resuscitate" as a tattoo on his chest? I used to joke about that, but this gentleman actually did that, and there was a whole big controversy about whether or not to honor that as a clear advance directive. And some physicians thought, well, you know, a person could change their mind, you know, what if they were drunk when they had that tattoo? I mean, people were arguing about it all over the place, and really, I think that was a person who was trying very much to avoid the situation. So it was like, wherever I am, here it is, here's the message, it's right here. You know, medical alert bracelets, or a card in your wallet, or some other way of letting it known that either you've made a clear decision that you don't want resuscitation, or this is the person to call if there's any question about how far to go. So and you guys all know that, but absolutely, our goal is to honor patients' wishes.
Yes, I see. Another question.
Yes, I saw Dr. Stuart Jameson the other night at a book signing, and he said people with heart transplants are living longer every day they do the transplants.
And the question?
Well, their comment on that.
Oh, I think Dr. Efron did mention that people with heart transplants are now living on average 8 to 10 years, right?
Considerably longer than that, actually. I was with one of the heart transplant doctors this morning over at Sharp, and he was telling me about several, he's a golfer, and he has golf tournaments for patients with LVADs and heart transplants every year, and he has several patients that have been out more than 25 years for heart transplantation. So
Well, the main thing, is, what he pointed out, you have to change your lifestyle also. You don't just get the heart transplant and continue eating and...
Oh, absolutely not.
You know, whole change of lifestyle.
yeah, no, I think that, you raise an important discussion. Whether or not a patient is a candidate for these therapies, to a large part, depends on their ability to have support systems, their ability to follow rather precise and difficult at times medical regimens, diet, exercise. It's not simply, oh, you've had a heart attack, nothing else is working, here's the transplant. And I will tell you that, there are lots of very difficult emotional and religious decisions and spiritual decisions where clergy is involved with, often with our hospice folks to help out. So Dr. Jameson, who I know as well, these are group decisions that are not easily made. To go back to the comment before about comatose patients, as you may or may not know, one of the treatments now is someone is on the streets and collapses and is immediately resuscitated but does not regain consciousness, is that most emergency rooms now will actually literally cool down their blood and put them in drug-induced comas until they can get the physician and other caregivers can give input as to what this patient would want. There's some anecdotal information that in patients that brains have been denied oxygen for a certain amount of time, that keeping their bodies cold, keeping them in barbiturate-induced comas may in fact improve their chances of not being in a vegetative state. So that's another point of the comatose patient where we try to buy time so that everybody can be on the same boat in terms of where we want to go.
Great questions. Yes.
Do you ever take into consideration age and the quality of life of the patient before he succumbs to, say, an arrest?
The question is, do doctors ever take into consideration age and the medical condition of the patient? And I think, you've said as much as they know and are able to, they do, but I'll let Dr. Efron comment on that as well. You might want to stand so.
Sure, I mean, that's something that we deal with every day, and as the population, if you looked at a graph of where the majority of people are, as you are well aware, it's not uncommon if you live to 60 years old, statistics are you're going to be living into the mid-80s because, I'm sorry? You can't hear well
Yeah,
enough.
just talk
I'll
close to
talk a
your
little
mouth.
louder. Once you've reached the age of 60, insurance statistics will show you that the chances are you're going to make it into your mid-80s. The quality of life takes far more precedent, as far as I'm concerned, than merely age and the comorbidities. What other diseases do folks have? I will tell you that I was among the first in town, along with my colleagues, to literally put in heart valves in patients over the age of 95. Okay, and these folks have gone on to have many years of productive life. So age in and of itself, though it is a factor, would rarely be a factor turning a patient down depending on their quality of life.
Any?
Comment on that?
Yes, another comment.
I just wanted to comment that obviously quality of life is a highly, personal issue. There are 95-year-olds that, have great lives and they would want this, but obviously no one's going to, force a treatment on somebody. I just want to relay a little bit of humor. We had an ethics consult a few years back on a lady in her late 90s who had collapsed at home and brought in unconscious, and it was clear she had some kind of catastrophic intra-abdominal thing, just bleeding or something bad was going on. So a decision had to be made, do we operate on her? They had to go do an exploratory. It's going to be a very challenging operation, very likely she's going to die on the table. We don't have any information, she had no advance directives, she lived alone, there were nobody to identify. We really had to make the decision right away, and because it was a go, no-go kind of situation. So a neighbor came in and told us a little bit about her, that she'd been very active and independent, had a very good quality of life. So I don't know if any of you know Paula Goodman-Cruz. Paula is a bioethicist in town. She organizes the county bioethics program. So Paula and I were standing there as the ethics consultants, like, how do we determine this lady's quality of life? Do we subject her to something very aggressive in order to hopefully return her to that quality of life? What are the pros and cons? So Paula, who is a much more put together lady than I am, she looked at the lady's hands and she said, look, she's clearly just had a manicure. She must be out and about. And I looked at my hands and I said, uh-oh, I'm in trouble. They're going to take one look at these and say, pull the plug. So I just tell that story because, we all define quality of life in our own ways.
Yes, Ken, back here.
I'd like a little more clarification on what kind of mobile identification for DNR. You said tattoos are iffy. There's some controversy. If you do that, that's pretty clear. But is a DNR medal or a bracelet considered more up to date than a tattoo might be? Or like the person said, if you collapse, they may not go through your wallet to see your stuff before they defibrillate or something. And so can you address that a little bit further or somebody?
In case you all didn't hear the question, the lady asked if the panel could comment on what might be the most appropriate kind of identification, mobile identification to carry, so that you got the kind of treatment you hoped you would get, or more likely didn't get the kind of treatment that you don't want. I think that dovetails with the question I had, so I'm going to throw it in with your question. We all have heard in Hemlock here quite a bit about the PULSE, which is the physician's orders for life-ending,
Life-sustaining treatment.
Life-sustaining treatment, and one of the questions on that document, if you remember, is if you're found, I think, unconscious or your heart stopped, I can't remember the exact wording, but if you're found unconscious and your heart is stopped and you aren't breathing, they give you two options. Do you want to be resuscitated or not? And I thought that was an interesting, hang on, I'm being
He's boinging.
stopped by my own timer that I was going to use on these guys. But in any case, it made me think, the comment that Dr. Efron made about if you, and I can't remember exactly how you put it, you might maybe give a little more information on this, about what your chances of walking out of the hospital in any state other than a vegetative state if you are found, if you have a cardiac arrest and you stop, or you stop breathing and you and your heart stopped and you're outside of a hospital somewhere. Maybe you could comment on that a little bit and then answer the lady's question about maybe what kind of...
Sure. This is all very, very time dependent. And in my estimation, 5 to 10 minutes is probably an excessive amount of time, which is pretty much what your response is going to be in any city other than Seattle. On the other hand, it depends on circumstances. We pull people out of frozen lakes where, you're talking 10 or 15 minutes, but in general, chances are less than 10%, 15% at most, that, you may be resuscitated, but you may leave the hospital in a situation that you would not have been happy with. I think from my standpoint, the medical alert bracelets are, that's something that we do look for rather immediately. And in my world, that would be enough to not continue a resuscitation.
You mean a pulse bracelet? A bracelet that says pulse, you mean?
No. You can literally have anything you want on the medical alert bracelet printed out.
Yeah, you can put down, you can either, there's 3 different places in California that you can get them from. And they can say DNR, or if there's pulse too, you can have both.
Right, to indicate that you have a pulse, right?
Now, from my standpoint...
there's a state registry, but I don't think it's used, nearly enough. Most people do not have their pulse or advanced directives on the state registry. I mean, obviously that would be the ideal, is if we all were in the state registry, and the minute you came in, they could go by a birth date or whatever and scan you and say, oh, no, this person has a pulse on file. But, maybe 25% of people don't have pulse, and so it's just not going to help in most situations.
I've talked to every EMT person that I ever see, and I ask them if they have both of them, will they honor it? He said, most of them say you have to have something in your wallet besides. One of them has a phone number, you can call up and check the pulse and everything. And the EMT guys say, and one of them said to me, if you got a tattoo, we honor it. But they all say you got to have it in your wallet besides that.
So, again, what's the time delay in making a phone call to find out your pulse? Right? I would tell you, out of all the circumstances I've seen that this audience should be aware of, is what happens in emergency rooms. Because often the communication about what you want, if there's not a pulse on record, becomes very difficult. Imagine yourself in a situation where you're in extreme pain or difficult to breathe. The doctor that you've never seen before says, do you want to go on a breathing machine if your lungs would stop, or should we resuscitate you if your heart would stop? And many, many people will say, don't do anything. Now, the way the question should be asked is, if there's a reasonable chance that your disease at the moment can be reversed, and you would be able to get back to a state which is identical to how you came in, but you temporarily may need to be on a breathing machine or have something of your heart done, are you willing to go through that? And you'll see how the answers change dramatically. And in my experience, that's the one thing that has really scared me. I've seen many otherwise completely healthy 30, 40, 50-year-olds that say, no, I never said don't resuscitate me. And then I show them the record. And I say, well, what happens if you've just got pneumonia and we can get you through this? Well, of course I want to be on a breathing machine. So be very, very careful the way it's worded. And I think emergency rooms are getting much more aware of those sorts of shortcomings. But really, that's a problem that I have seen very regularly.
I thought I'd just kind of
alter this slightly because be careful what you wish for. The reality is that back in the 60s, 80% of us died suddenly. We didn't have all this fancy equipment. We just died suddenly. There was no debate. Well, the good news is now it's down to 20%. So 80% of you guys will not have to worry about this circumstance because we will know well in advance that you're on your way out and you'll get on hospice, you'll be in a skilled facility, and no one will come in to resuscitate you at that point. Our hospice staff is not obligated to do resuscitation. The 95% of our patients don't want to be resuscitated. So if you're fearful that this is going to happen to you, I think that it's statistically not very likely anymore because those diseases we've taken care of. And the other thing I would say for myself, because I already have a pulse even though I'm not particularly ill, is that if I end up in an emergency room, I was driving, I had an event, I'm comatose, I come to the emergency room, eventually, not months, but within days, they're going to find somebody who knows my wishes. And I hope all of you have made that very clear. And when that person shows up and they see me on a ventilator or whatever, they go, no, he didn't want this, stop. And no, pulling the plug is not such a horrifically challenging thing. If everybody's got it well written out, it happens very frequently that you go, oh, well, we didn't know, so we just did this until you got here. And now that we know you're here and you agree you're his spokesperson and that he wouldn't want this, we'll back away. I'm not going to be stuck on a ventilator for the next 5 years. In fact, I won't be stuck on it for more than a few months, even if they let me be, because a lot of these patients end up with all kinds of complications, the ones who are stuck on ventilators. So I think I wouldn't be quite so fearful of people not following your wishes, because by the time you get to that point, you'll be with hospice, you'll be with the palliative care team, and we will honor those wishes.
Or in an emergency room, like you said.
Indeed.
You know, somebody would come in an emergency.
Yeah, hopefully.
Yeah.
Yeah, obviously, this underlines things that we talk about in here all the time, and so in some sense we're preaching to the choir about the importance of having advanced directives, spell that very carefully, about the importance of having a pulse if you are in a situation where that is appropriate in particular. And so these are all things we've discussed, and really what we're hearing today is in some sense just underlining the importance of these things. There are a couple other questions I see. Yes, this lady right here.
I have a question for Dr. Efron. Could you discuss ablation procedures?
The lady asked the doctor to talk about ablation procedures. And he could tell us what that is.
So the question revolves around ablation, which is a mechanical way in patients with certain heart rhythm disturbances to electrically normalize the heart. And often it depends on what sort of rhythm disturbance is occurring. Fortunately, most of us that have heart rhythm disturbances are not life-threatening, and so the decision, if you're a 25 or 30-year-old person, revolves on how often is the arrhythmia occurring, and most of the time it's going to result in either palpitations or, at worst, blacking out spells. So how often does that happen? And more importantly, at the age of 25 or 30, do you want to be on heart medications that can have their own side effects and toxicities for the next 40 to 50 years? So the success of ablation, in large part, revolves around what type of arrhythmia is present. Where it works best is something called a supraventricular arrhythmia, where the heart beats very rapidly but regularly. Most of the time, the success rate is in excess of 95%. If we deal with the more common issue that most people in this room are familiar with, something called fibrillation, atrial fibrillation. Again, there are several subtypes of atrial fibrillation. And although on television you may hear that the success rate borders on 80 to 85%, that's actually not true, because if you put monitors on patients that have had fibrillation, even if they're not having symptoms any longer after their ablation, if you put a 24-hour monitor on, you may see that even though you're not having symptoms, that fibrillation can recur. And the thing that most of us with defibrillation are worried about, as has been documented, is falling episodes. Falling on your head with a blood thinner on board, not a happy idea. So lots of better blood thinners are coming along, but again, to in general talk about ablation, in certain situations, it's a wonderful therapy. It can prevent a lifetime of medications. In other more common situations like fibrillation, it has to be very individualized with the knowledge that it is not curative, and often you may have to go back on blood thinner medications. And nowadays there are also some other options for folks that for one reason or another can't be on blood thinners. There are certain devices that can be placed in areas of the heart where blood clots are likely to form to make sure that blood clots can't get to that area. So there are lots of different ways of approaching it. I hope I helped you out there, but it's really a variable situation.
There was somebody else I saw back here that had their hand up, I think. Well,
I see commercials where there's something you plug into a cell phone and you put your fingers onto it and it transmits it.
A live cord, yeah.
How effective is that and what does it do?
I'm not sure. Boy, we're working Dr. Efron pretty hard here.
Yeah, these guys got to get some work in there. So most of the smartphones now will have an app where basically you can just put your thumb on the screen itself and it will record your heart rate but not your rhythm. There are now apps that are reasonably good at recording rhythm. And we do this for several reasons. One, if we're talking about a patient with palpitations, but every time they come into my office, they're feeling fine, and we do cardiograms, we don't find anything, you're not going to put somebody on medications until you know what you're treating. The other reason for it is for patients that are already on medications. How efficacious are the medications? Can we really justify putting somebody on medications for a lifetime unless we know, one, is it working, and secondly, how often is it not working, right? So it is readily available. Basically, it's transmitted often Bluetooth right into a physician's office, but more generally into a central monitoring station. That station will have certain criteria to inform your doctor either right now or tomorrow or the next day, depending on how serious the arrhythmia is. So it's something that has been on board now for probably 3 or 4 years, that physicians, particularly cardiologists, and what we call electrophysiologists, who are guys that specialize only in rhythm disturbances, do use. There's a little bit of problem sometimes with the actual accuracy of the transmission, but for the most part, it's reasonably good. And if we go farther than just the phones, again, if you're not having symptoms, but the arrhythmia does occur, you wouldn't have your hand on the phone because you're not aware of the arrhythmia, but we can actually implant into the chest for up to years at a time, tiny little devices under the collarbone that can transmit arrhythmias all of the time, whether or not you're symptomatic from it. So that technology's been around for a while.
Thank you.
Sure.